It's
Wow.
already started to expand.
Look at that. Wow. Wow.
Welcome back to this month's CHIP Update series. My name is Sanjog Kalra. I'm an interventional cardiologist and cardiac critical care physician at Toronto General Hospital and an assistant professor of medicine at the University of Toronto. And it is my distinct pleasure to welcome Dr. Tim Henry. He is the Lidner Family Distinguished Chair in Clinical Research and the Medical Director of the Carl and Edith Lidner Center for Research at the Christ Hospital in Cincinnati, Ohio. And he is also an interventional cardiologist that needs no introduction on the national and international stage as the incoming president of the Society of Coronary Angiography and Intervention. Dr. Henry, thank you so much for joining us today.
Yeah, absolutely delighted to be here with you tonight.
Wonderful. I'm looking forward to chatting a little bit with you over the next few minutes about how this pandemic, this total wrench in all of our practices, has changed the way we perceive what we do every day, particularly as it relates to the complex PCI space, and perhaps get some of your thoughts and advice on how we can move our field forward, keeping COVID in mind, but making sure that we get the best care to our patients.
Yeah, it's amazing when you do, because it's remarkable, because a year ago, if we were having this conversation, right, I certainly wouldn't be recognized as a COVID doctor. And now, over the course of the last year, sort of, it's dominated our time and attention.
Mm-hmm.
But I think we've made progress, and so I'm looking forward to the conversation.
Absolutely. So maybe we'll start there. You know, having had so much experience, not only with high volumes of COVID in the United States, but as an experienced interventionist, how do you feel the current pandemic has sort of affected the practice globally of interventional cardiology? And tell me about the ways you've felt those changes in your practice and how you've managed them.
Yeah, so certainly, without any doubt, this has been the most disruptive disease process, I think, that's affected cardiovascular in my career, certainly. And if you think about it this way, COVID affects us in so many different ways. Number one, we know that patients with cardiovascular disease are at increased risk. So there's higher mortality when you get COVID. Number two, we know that people, when they're hospitalized, the patients who have positive troponin, which occurs about 15 to 25% of the patients who are admitted with COVID, and we know those patients are at significantly higher mortality. And that clearly, from both a diagnostic and a therapeutic, has been challenges for cardiologists. And we'll come back to that in a minute. Number three, this issue about COVID positive patients who have ST elevation is a fascinating group, and we just found out that the NACME registry was just accepted for publication in Journal American College of Cardiology, and was a TCT late-breaking trial. So clearly, that's an important issue that we'll come back to. But then there's the unintended consequences. So if you look at in some ways, the cure has been as bad as the disease. And certainly in March and April, we published data that showed a 40% reduction in patients presenting with STEMI activations. Because, and again, these are not COVID positive patients, but these were patients avoiding the hospital. And we know that that affected both acute coronary syndromes, it affected structural heart disease, and we saw a remarkable increase in mortality related to the unintended consequences, the effects of the cure. And then I think the fifth thing for me is it dramatically affected practices. It affected interventional cardiology training programs. It affected hospitals. It affected cardiac cath labs in terms of what we do and how we do it. So clearly, in multiple different ways, COVID's had a dramatic effect on us this year.
So, I mean, that was so beautifully laid out. It's affected our patients, it's affected our care environments, affected the care that we deliver, and it's affected our outcomes. So how do we start, wheeling this backwards? How do we start unraveling this mess where we're able to get our patients back into the hospital, particularly in situations like STEMI? Now, I had the privilege of being on some of the early emails when the COVID STEMI registry was being formed with Bayam Dagani and some of the other operators here in Canada, with partnerships amongst those of you in the United States, and I think we've all noticed that in STEMI in particular, I mean, the outcomes are so bad often because they present late, but that the STEMIs themselves look different, right? Tons
Yeah.
and tons of thrombus, weird low left ventricular end diastolic pressures instead of high left ventricular end diastolic pressures. The phenotype is different. So how do we get our patients back in, and then how do we prepare to manage heart attacks unlike those we've seen before?
Yeah, so there's two separate questions. So first, maybe let's talk for a minute about NACME, because I think people can be read. So this is the North American COVID ST elevation registry. So in March, what we did is we recognized very early on in the pandemic, on social media actually, that COVID positive patients were presenting with ST elevation. And there were a lot of unusual presentations. So patients who had, even though they had clear-cut ST elevation, had no clear culprit. And there were also patients who were very thrombotic, but it was clear that something unusual here. And so what we did based on this is we very quickly with SCI, as well as the Canadian Association of Interventional Cardiology. So I love this part because it's like the best cooperation we've had with societies. So SCI, CAIC, as well as the ACC Interventional Council combined to put together a registry. And really within a 2-week period, we had a case report form, we had a consent form, we had a central IRB, we had a design paper within a month and published, and we are enrolling. And if you think about this, this all started in March, and in October, we were presenting late-breaking trials with almost 300 COVID positive patients, and we did it with no funding. You know, effectively. We subsequently got some modest funding to help support it. But you know what it was interventional cardiologists wanting to take good care of people, right? I mean, it was people recognizing a problem and doing it. So what did we find from this? And so what we did is in the first, we have the COVID positive confirmed patients is one group. The COVID suspected patients is a second group. And then we had a historical controls from the Midwest STEMI Consortium, which is a very large STEMI registry of 20,000 from 4 large regional STEMI centers. And the registry is unique in that it's consecutive patients that are STEMI activation, no exclusions. But it's 4 large regional things, so and it's 20,000 people, so it's a great comparator group. So really interesting, if you look at the COVID positive things, what are some things? First of all, only 30% of just over 35%, 30 to 35% are Caucasian. Well, when have you ever seen a STEMI registry that had that few Caucasians, right? And so more than 35% of patients were Black and more than 35% of patients were Hispanic. So a predilection, an ethnic difference that is markedly different than the suspected patients, and of course, markedly different than the controls. Controls might not be perfect because it was more Midwest, but still, that's interesting thing number one. Interesting thing number two is 45% of the patients were diabetic. Also much higher than the suspected and 25% in the historical controls. So again, a predilection for diabetes. All right, number three, about 20% of the patients, even though they had ST elevation, didn't go to the cath lab. So that's a very interesting great patient population that we'll look at. And part of that is futility. Part of that might early on being fear, but it's a different patient population. But then if you go to the cath lab, it turns out about 30% of those patients had no clear culprit, which is not, you know, it's about double what you would find normally. And that's a very fascinating group of patients. And then the final insight I think that's really interesting is there's a much higher incidence of in-hospital development. So, and we know that in-hospital STEMI is a much higher risk patient population. In fact, the worst place to have a STEMI in North America is in the hospital. And so all of those, I think, were interesting insights. And then when we look at actually the results, the nice thing about this registry, which is more than 60 sites, more than 300 COVID positive patients right now, and about 500 plus COVID suspected patients, and then we did 2-to-1 match controls, is that the mortality overall in the COVID positive patients was about 33 to 32 to 35%. Whereas in the suspected patients, it's about 12%. And then of course in historical controls, it's about 4%. So not as high as what, God, people calling me everywhere, not as high as what you would expect, what you saw in some of the literature reports, which were up to 75%. It's not that high, but it's 30%. And now we have a lot to learn, and we're still enrolling patients, and we're doing long-term follow-up. We're also going to look at temporal changes. We're going to dive into the ethnic etiology. So there's a lot to learn from NACME, but I do think that it's helped inform our care. And so I think this, the next step to talk about is, what about STEMI care in America? And that's a huge issue. And I think in March, there was a lot of discussion about, should you go to the KF lab? Is it safe to go to the KF lab? How should you treat these patients? And, there was articles written, use lytics, et cetera. And I think we'll cut to the chase on that. This, I think, has really been a remarkable year in terms of, again, collaboration and cooperation, ACC and SCI. And we put together what I think are great guidelines, again, published in JACC in April, that gave guidance of how interventional cardiologists should prevent with STEMI. And the answer is, do the same thing you do, it's best care. Take them to the KF lab. And I think it was clear that it's safe to do that as long as you're using adequate PPE, and which people are. And I think that I think most people now are very comfortable doing it. Well, another thing we learned from NACME is that the majority of patients in North America, in fact, there wasn't a shift to lytic. They went to the cath lab and they got primary PCI. And so I think that's another important part of the guidelines is, good care is good care no matter where you are and when it is.
So that was truly extraordinary in that not only are there a bunch of collaborations that are critical to be able to generate these data and these conclusions, but that they've been synthesized and crystallized so quickly and are being now disseminated to the interventional community across North America and the world. And I guess that sort of segues into something else that has become a hot button topic within the COVID environment and what we do, which is, how do you continue to educate one another and our colleagues, right? I mean, we in the complex PCI space in particular have always benefited from on-site education programs, proctorships, and these kinds of things, where within the sort of post-pandemic era, perhaps the amount of on-site proctoring is limited as a result of travel restrictions and what have you. As sort of the incoming president of SCI and as an experienced member of the community, what are your thoughts on where education is going to go in the post-pandemic era, not only within things like STEMI care, which you've outlined already, but complex PCI education, where a lot of it is very nascent. You have Rob Riley and his recent consensus document. How do we get that translated into the hands and the decision-making, so to speak, of our colleagues without being able to visit?
Yeah, really. So it's a great question, and it's a broad question. So let's start with the first part is, what was SCI's response, I think, to the pandemic? So first of all, I think it's remarkable what really we did. First of all, clearly, if you look at cardiovascular patients and cardiovascular interventional cardiologists, there's never been a time when you needed somebody more to step up and really make a difference. And I think SCI played a role in a number of things. Number one, important surveys that looked at interventional cardiology fellows and the implications of cardio training, because all of a sudden, when you take away electives in March and April and May, and then all of a sudden the volume went down, right? And patients were coming. So that huge implications for, fellows who are trying to train and sit for the boards and things like that. So that was number one. Number two, we did a survey from interventional cardiologists and cath lab directors in terms of how was it implicating it. I had the benefit, I was talking to people every day from all over the United States and Canada and getting insights into what was really happening. But we need to get that information out to people. And so I think we did that the surveys was really helpful. And I think 3, the guidance documents, I think, number 1, this was, we didn't just do this on a whim. We spent a lot of time talking with people, and it was based on data that really helped inform. And I think the nice thing, think about this, it came out in April, and I read that document today, and I think all of it's true. And so I think it was really helpful that very early on, we were able to inform management. Then another, I think the registries, I think NACME, and then we also have a mechanical circulatory support registry that were very important. And then another really important issue was, how do we get back to work? And I think that, you know, the startup, which occurred really in May and July, June and July, as people were going back, about safely starting up with electives, et cetera. And I think, again, that there was some variability across the country, but I think we did it very quickly. You know, basically, you know, we were back full time in middle of April here in Ohio. And then I think the last thing was, Sky made a big difference in this. We published, this is kind of a remarkable story. We noticed that there was a decrease in STEMI patients. And this was, again, social media in March. People were like, where have all the STEMIs gone? Sure. So we got 9 large regional STEMI systems together. And on April 1st, I had data from 8 of them of their STEMI volume for March. And on April 2nd, I had 9 large STEMI systems. That paper was submitted to Jack on April 3rd, and it was accepted on the 5th and published, I think, on the 6th. That was March data. And it showed this 40% reduction in STEMIs, and people said, of course, we have to deal with this. And so Sky did a really important thing. It's called Second Still Count campaign. And basically that, I don't know, you'd have to check exactly, but I think we started doing that in April, certainly in May. And a huge number of broadcasts all across the country of public service things saying, come to the hospital if you have chest pain because it's safe.
I remember seeing those commercials.
And so I think, you know, for me, I think Sky did a terrific job this year. And I also think the partnerships with CAIC and with ACC were really important. And hopefully we keep that going because we can make better care for everyone.
I think tremendously innovative in that process is we typically reserve knowledge translation and outreach for our colleagues, right, for other doctors. But the nice thing about this campaign is that it's grassroots, it goes to patients. It reminds them that they have support and structure for their healthcare and that we are open for business. And I think that's so important for patients to recognize so that they know that when they come to hospitals and when we take care of them, they're still safe and they're still going to get the very best care possible, supported by consensus guidelines, supported by the evidence.
Yeah, no, critically important, really very important. And so, you know, this I think is, you know, really been a fascinating year. And then I think now we still have a lot of work going forward because clearly we have better treatments and we have better recognition and things like that. But now how do we get back to normal? And education-wise, I think, what do I miss? You know what I miss is the in-person conferences because I think the, you know, the collegiality that we have in interventional cardiology is important. And I think a lot of the things that we learn, you know, Zoom's okay. This is good. It's good, but it would be much better if we're in person and you can actually have that personal conversations about how you deal, you know, whether it's the CTO case you did last week or how you're running your CICU. I think those are critically important for us to get back together.
I think that, that knowledge exchange is key, but still on the subject of education. I mean, I remember how my own CHIP fellowship began this road that I've taken down with my, you know, with my career so far. I ended up in a great meeting and found the people that are now my mentors, followed them around for a few minutes and said, this is what I want to do. I'll do anything you tell me. And I came to know afterwards that the reason I had that opportunity was because I came up to them, I talked to them, and I showed them that I wanted it. And I think that that ability to do that in person is so critical at these meetings.
It is, but I will say this, you know, you look at this, the good and the bad, right? we just gave some examples where I think Sky really stepped up, and I think the collaboration between societies was really better. But also, like this series that you're doing now with Rob and with TCTMD,
Mhm.
it's fantastic in terms of we found new ways to educate people.
Absolutely.
And so, there are things we can learn new things and do new technologies, but being in person is still, we're not going to lose that. It's critically important. So I'm
Absolutely.
hoping this year that real TCT is back in person.
As we all are. So with that, I want to thank you so very, very much, Dr. Henry, for the time that you've spent with us, for the insights that we got hot off the presses with MACME and with the Sky consensus plans. And I look so forward to seeing you in person soon at the next in-person meeting we're able to have.
Yeah, I enjoyed this. I really appreciate it. I think the series that you've been doing is fantastic. And so thanks for having me.
Thanks so much.